Dr. Ertem, congratulations for that great work that you've published in GIE.
Thank you.
As I mentioned before, it looked like it took quite a bit of work and effort to put that together. I'm going to ask you a few questions about it, just because I'm interested in the subject, and found it kind of an intriguing paper that, in some ways, raised some more questions than that maybe it answered. So, just to recapitulate, you looked at a large series of colonoscopies from, I believe it was 4 medical centers, 120 physicians, gastroenterologists and non-gastroenterologists. Is that correct?
Yeah.
And you were focused on the colorectal cancers that were identified during these diagnoses. How did you exactly identify those? Were those from the Department of Pathology or from a data registry, or how?
We initially utilized the National Language Processing System, and we looked at all the colonoscopy output reports, and then kind of searched the terms that will identify the possible diagnosis of colorectal cancer. Then we also use the same system for pathology reports. And then once we identify those potential cancer diagnoses, then manually we reviewed those cancer diagnoses and then kind of justify the cancer diagnosis among those large group of outpatient colonoscopy exams.
And your focus of this report was on interval colorectal cancers. Obviously, that would be of concern to a clinician that he might have missed something at the previous endoscopy. How do you differentiate, how do you know that these were in fact interval colorectal cancers versus de novo colorectal cancers?
So in our paper, we don't necessarily focus on the etiology of potential interval cancers that we pose while calculating incidence of these interval cancers. What we wanted to do, rather than focusing on the etiology of each cancer diagnosis, we wanted to put a context for a clinician in the field that one might encounter interval cancer, and what would that mean in terms of their practice, why they should be concerned or not concerned, and what would be the expected incidence that they might face during their clinical routine practice. So we didn't differentiate within those cancer diagnoses whether de novo or interval cancers. What we utilized the literature review, and we kind of used the interval cancer rate from the literature, and obviously there was one caveat that the definition of interval cancer in the literature in terms of the time frame is different. That would be the one caveat, but the rate that we use, 5.25, seems to be consistent throughout different studies, including the meta-analysis, the most recent one. So then we feel confident that this kind of respectively shows the potential true incidence of interval cancer rate.
So just to clarify, I believe in your study you identified 526 colorectal cancers during these endoscopies. That was an incidence rate of 5.25, around that, as I recall.
Yeah, so we again, as you said, we looked at 93,000 outpatient colonoscopy exams, and we first only looked at the cancer diagnosis rate out of those, all cancers, which turned out to be a 0.6% of those colonoscopy exams, which was also consistent throughout different healthcare systems, including academic environment versus private practice versus mixed group. Then using that rate, and then we combine that with the reported rate of interval cancer from the literature. So using those two, then we come up with the estimation of one interval colorectal cancer, possibly for every 3,174 outpatient colonoscopy exams.
All right, that's a good explanation. And I thought it was very interesting you tied it to the adenoma detection rate. So in some ways your paper was a push to drive quality assurance, if you will, to make people feel guilty if they had a low rate. But why don't you tell us what you found once you screen these per the documented adenoma detection rate for the practitioners?
Yeah, so obviously one would expect that this incidence rate obviously will change with the colonoscopy volume and adenoma detection rate. That's why we kind of tied up in the end with the paper dose. We utilize our own colonoscopy volume data out of those 93,000 colonoscopy exams. And then we also utilize the Corley et al. Paper from 2014, and they use their adjusted risk ratio for interval cancer rate. Then use the calculation model and come up with some kind of a figure 1 in the study that shows the effect of both volume and adenoma detection rate on the expected incidence of interval cancer rate. So what we find out in the end, even the best endoscopist with the highest adenoma detection rate should expect to have interval cancers attributable to them. And the number that we find that at a median colonoscopy volume endoscopist in our population, it was 316 colonoscopy exam per year, would expect to have the 2 to 4 interval cancers attributable to them during their supposed 35 year of career practice. That's why we think that as a colonoscopy adverse outcome, colonoscopy perforation, which is an supposed outcome of adverse outcome of exams, we think that interval cancers also should be seen as the potential adverse outcome of colonoscopy exams. And most importantly, the most strikingly, the rate that we report as 1 every 3,174 for interval cancers is coincide with the rate of colonoscopy perforation, which is like 1 every 3,000. So that's why we come up with that conclusion. But obviously, this does not endorse or excuse interval cancer diagnosis. That wasn't the message that we wanted to lay out. We wanted to just put a context for clinicians to use.
I think an interesting thing about this is the definition of interval colorectal cancer is difficult to really put your finger on, and it seems like it really would vary according to the reason for the colonoscopy to be done. So a screening colonoscopy for a high-risk patient like a Crohn's disease patient or UC patient might be different than a routine 10-year screening. So how did you sort out those two, the high risk versus the low risk group?
So in those 93,000 colonoscopy exams, we had only looked at the outpatient exams, and then we identified those cancer diagnoses into screening versus non-screening cancer diagnosis rates. And also, I think is most strikingly that the cancer diagnosis rate was twice higher in non-screening colonoscopies versus screening colonoscopies at what one expect. So then we can come up with the argument, as you suggested, that one would expect higher rate of interval cancer diagnosis among those high-risk populations. But we use the mean rate of cancer diagnosis of 0.6. And for screening colonoscopies, it was 0.3. And for non-screening, it was 0.8.
Much higher, of course.
So we kind of use the mean between an endoscopist who performs a lot of high-risk population endoscopy should expect higher rate as they can use still the data, but they should see in their perspective of patient population.
And as a surgical endoscopist, I thought it was interesting that you included those 13 practitioners that were non-gastroenterologists. I presume they were mostly surgeons, probably not family practice or anything. Why don't you tell us real briefly kind of what the interval cancer rate was in those practitioners?
So we, as you said, the surgeons that they tend to do colonoscopies on a more high-risk patient population, that we wanted to include that into our analysis. And once we differentiate both groups, the surgeons and the gastroenterologists, that difference did not change. So we think that this data holds up still for even the surgeons, given their population might be different, but at least in our study, we didn't see a difference in terms of expected incidence of those. Meanwhile, we should also say that in our inclusion criteria, we only again used outpatient colonoscopy exams, and we excluded all exams for patients age less than 40 years old, and we also excluded IBD patient population. So that should also be notified when they take into account into this paper results.
So rather normalize your data
Exactly.
and not have outliers. Yeah, I really don't have any other questions. If you were to give a self-criticism of your paper, since it's rather unique because it's purely a modeling exercise in some ways, if you wanted to validate that in a prospective or a registry-based method, what would you expect the weaknesses of your modeling methodology to shake out on a validation?
As you said, we wanted to provide a modeling and estimation based paper. One limitation of this paper was the colonoscopy reports prior to our inclusion, the start date, was not available to us. So that's why we were not able to specifically identify among those cancer diagnoses which are the ones exactly interval cancers. That's why we had to use the literature review and mean interval cancer rate. So that would be the one major limitation and of self-criticism of this paper would be. But regardless, again, we think that the rate that we adopted from the literature was quite consistent, and then our the robust number of outpatient colonoscopy exams of 93,000 that suggests the cancer rate that was, I think, combining those or still provide the appropriate context for clinicians.
As a trainee, has it changed the way you think about your practice in the future? Have you gonna?
As we started, interval cancer diagnosis is a kind of a worrisome diagnosis, and clinicians take that as a kind of they might think as a quality measure endpoint, but
or a complication,
as you said. What we think is it's hard to use that in that context because time to event to occur is very long, and the absolute rate of interval cancer is also low. So combining those together, we think maybe more immediate surrogates of colonoscopy quality measures such as ADR will be more feasible rather than using interval cancers for colonoscopy quality measures.
Okay.
To take home.
Well, once again, congratulations.
Yeah, thank you.
Nice paper, and I was glad to discuss it with you.
Thank you. Thank you very much for having me.